just to say hi to everybody who's joining. We're just going to give it a couple more minutes because people are joining kind of on the dot of 12, but then we'll get started in a couple of minutes, if that's okay. Okay, just give it one more minute and then we will get started, I think. That's okay. Okay, I think we should probably get started if that's all right. So welcome to Neurodiversity Celebration Week. My name is Jenny Rayson and I'm from ADDVance, the Autism and ADHD Trust. And I'm very pleased to be hosting alongside University of Hertfordshire, or we're very pleased to be hosting alongside University of Hertfordshire series of Lunch and Learns this week in support of Neurodiversity Celebration Week, of which this is our first one. For those of you who don't know or haven't heard of ADDVance, we're a Hertfordshire-based charity offering a range of services to parents, carers and professionals in the support of understanding of autism and ADHD. If you want to find out more about us, please check out our website to find out who we are and what we do, and follow us on Facebook, LinkedIn, or Instagram. I'm not going to say any more about me or ADDVance because I want to hand over to Amanda and Danny, who's actually going to be doing the talk today. So yeah, I'm going to hand over first to Amanda, who's head of the Psychology and Neurodiversity Applied Research Unit here at the University of Hertfordshire. And then she's going to introduce Danny, who's the main event. Okay, I'll hand over to you, Amanda.
Thank you. So, hello and welcome to Neurodiversity Week. We're so excited to be having Danny talking with us today. She's doing her PhD looking at the journey of diagnosis for tic disorders in adulthood and is shining a light on a really underrepresented area. And we're thrilled for her to be speaking. What we're going to ask is if you've got any questions to put them in the Q&A, only we can see them and we'll direct them to Danny at the end of her chat. So just pop them in the Q&A. Okay, and I'm going to head over to Danny, who's going to start her talk.
Thank you very much. Well, it's now officially good afternoon to everybody. Thank you very much for joining today. So as stated, my name's Danny Phoenix-Kane, and I'm actually a PhD student at the University of Hertfordshire. And again, I'm very honoured to be presenting on Tourette syndrome in adulthood today. Thank you so much to the University of Hertfordshire and ADDVance for hosting. So this presentation, I'm going to give you a bit of a whistle-stop tour. So I'm going to look into what the background of what Tourette syndrome is. You may already have some preconceptions or knowledge of this already. Then we're going to move on to look at the kind of key points on the course of tic disorders over the lifespan. Have a look into the impact of aging with Tourette syndrome, and then a wee insight into my research looking into late recognition. Now, full disclosure, I actually have Tourette syndrome, so I may tic during this presentation. Okay, so what is Tourette syndrome? So Tourette syndrome is a tic disorder, and it's characterized by rapid, sudden movements and or sounds called tics. The difference between Tourette syndrome and, say, chronic tic disorders is that Tourette syndrome tends to invoke both. So both vocal and motor tics, whereas chronic tic disorders are either focusing on one, the motor, or the vocal. And it's considered neurodevelopmental. So it's typically considered to start in childhood and then can continue into adulthood. And there is a bit of debate or exceptions in terms of whether adult onset does occur. And that's usually considered to be part of like an external insult or trauma that's happened in order to cause those. And there is a gender variance, so it's typically more common in boys, but female presentations may present later. There's no treatment for Tourette syndrome. There's no cure for Tourette syndrome. However, a lot of people manage it through self-help. But there is therapy and medications available. And tics actually wax and wane, so there's a variability in regards to how they present, and they're often preceded by what's called a premonitory urge. So premonitory urges are kind of uncomfortable, like physical sensations that occur before the tics start happening. And because there's kind of that warning signal almost for some tics, suppression of an impending tic can be possible, at least for a while. But this suppression often takes a lot of effort, a lot of discomfort, maybe to the person in order to perform. And there's kind of a trade-off. So there might be like a rebound of tics after the fact as well. So tics themselves are often described as involuntary or involuntary in nature. And others may misunderstand that involuntary nature of tics because they assume that the tics may be controllable intended actions, especially when tics are invoked by maybe environmental stimuli around the person themselves. One of the quotes that I really liked from when I was interviewing my participants was that there's a kind of almost assumed need for control or an assumed ability to control when progressing into adulthood. You know, you're grown up now, you should be able to control it. It should be something you know what you're doing. So let's address the elephant in the room. A lot of people kind of focus a bit more on, especially in the media, in terms of the sensationalism of tics and Tourette syndrome. A lot of people will focus on kind of the swearing part of it, so coprolalia or copropraxia, the demonstration of obscene gestures. And you know, this has obviously a societal stigma involved in and kind of exacerbates that thing. So there's probably commonly what you do see in the media is that kind of portrayal of it. So Tourette's itself is, I mean, as you can see, it's a visible condition, although it does have kind of internal elements to it in terms of that suppression, in terms of just having to manage it day to day. And that visible aspect of it obviously draws unwanted attention, you know, maybe negative comments, and it's a difficult thing to hide sometimes. So there's obviously that misconception as it's a swearing disease, whereas only about 10% of people who have Tourette syndrome actually have that swearing component to them. And again, we're often the butt of jokes or humor in regards to it. And, you know, I often allow people to, you know, sometimes tics can be funny, but it should be an inviting, that you're laughing with the person rather than at them. And it can create a climate of like almost acceptable discrimination and demean and invalidate the experience that the person has of having Tourette's itself. So the next part, as I said, we're going to look into a paper from Black et al., a really good paper about the course of tic disorders over the lifespan. And I'm going to give you 3 key pointers that I found really interesting about this paper. So point 1, do tics ever truly go away? Now, again, it's debated. So often there seems to be an improvement. So from the transition from childhood into adolescence, it seems to kind of go in a rule of thirds. So in a third of people, the tics may disappear. In another third, they may lessen or improve. And in another third, they may continue at the same level. And in terms of recognition, it's actually more common for occasional recurrences of mild tics to happen through adult life. And they actually could be a remission of decades before a reoccurrence of tics actually happen. And those that might report remission may have mild tics when observed alone. So for example, they highlighted a paper whereby there was a clinic where people were being discharged from the services, and they filmed them as they were going into the before they went into the appointment, and they were still exhibiting some mild tics even though they reported that they no longer had tics. Point 2, can adult onset occur? So again, as I've mentioned, it tends to focus on having an external trigger, such as disease, drug, or trauma induced, and it might have a genetic basis. But there are challenges in terms of adult onset. So the diagnostic criteria for Tourette syndrome and tic disorders in general requires the onset before the age of 18 or 21. And some adult presenting cases actually might not even recall having tics because they might have been quite mild at the time, or they may have been labeled differently, like habits or twitches, and they might not realize that they had them. So obviously more research is required in this area, and hence why I'm doing some of the research that I'm doing. Point 3, in terms of the prediction and outcome of tics, or the prognosis. So in prediction, so there are observed brain maturation differences between children and adults with tic disorders, and compared to tic-free controls. But at the moment, they've not had any factors which confirm or predict kind of the type of course tics may have going into throughout the lifespan and the persistence into adulthood. But generally, the outcome or prognosis is good with the majority of people. Even those with severe tics in childhood will experience a substantial improvement as they transition into adulthood. So I'm going to touch a bit upon the impact of aging with Tourette syndrome. So in terms of quality of life and mental health, obviously the stigma around the condition might obviously impact on mental health. And actually the impact of the kind of disruptive, chronic, sometimes always present tics, can kind of cause certain aspects to occur. So you might be anxious because you'll be anxious of other people's reactions to tics, for example. Perceived kind of lack of control, what's actually me and what is actually the Tourette's, for example. The impact of constant suppression. It obviously has an impact on kind of social interaction. So people may tend to encounter more social difficulty. Obviously, the older you become, the more kind of chronic health conditions may occur, which maybe can exacerbate tics as well. And people with tics tend to struggle with kind of mood, anxiety, and depression as well. So Tourette's is not often kind of happens alone. There are co-occurring conditions that can kind of straddle alongside it. About 80% of people have a co-occurring condition. And again, those actually can impact not only on the quality of life of the person, but also the tic presentation might change due to the co-occurring condition too. And something I found really interesting was that people with Tourette syndrome or chronic tic disorders might have a higher risk for obesity, type 2 diabetes, and circulatory system diseases compared to the general population. So actually there's an impact on the physical health as well as mental health too. Now, obviously in adulthood, we have to go into employment and getting a job. So there's impacts there. So previously, especially if you've had it in childhood, you might have interference with schooling, assessments, and the ability to get things for job requirements, for example. Again, interview panels, there's stigma around that. Whether to disclose having Tourette's before you have the interview. I actually sometimes struggle with that myself, whether I disclose I have the condition because of the stigma potentially involved and the impact it might have on my chances. And also the constant masking you might have to do during that process. Aspects of employment. So any accommodations you might need flexible working, for example. I take regular breaks in my line of work. It may affect your ability to have a driving license even, because if they're quite severe, then that might mean you not be able to get a driving license. There's a kind of waxing and waning of tics, as I've mentioned before. And even some of my participants actually quoted that they kind of overcompensate. They try harder at their jobs just so that they can prove themselves, because despite the fact that they have Tourette's, they're being able to perform in their role. And in terms of the Equality Act, over 50% reported kind of discrimination in the workplace due to Tourette's, and higher tic severity correlates with higher unemployment rates. Again, and I mentioned this before in terms of like actual physicality of tics. So tics themselves, especially if they're repetitive movements, can cause pain. And that pain may also exacerbate not only the tics, but the premonitory urge to do the tic, for example. And tics can sometimes cause injury to the body, depending on what the nature of the tic is. So, Taylor, Anderson, and Davies looked at kind of this cyclic kind of nature of pain and tics that kind of occurs. And also some research suggests some links with hypermobility spectrum disorders, for example, but this kind of constant ticking can have an impact on like muscles, joints, and connective tissues. And as I say, have actual genuine physical consequences, even to the point where people might need either mobility aids or stuff to be able to manage their condition in extreme cases. All right, so to my favorite part, this is looking into my research a bit. So I'm looking into kind of the late recognition of chronic tic disorders and how people kind of relate to them and how they understand what's going on in adulthood specifically. So this slide is looking into essentially that tics are kind of belong to a range of different movement descriptors, as you can see on the left-hand side, and sometimes it's quite difficult to distinguish between those movement descriptors. So I've got a couple of different videos which I'll show in a minute in terms of differences in movement that might happen. And as I've mentioned, there's co-occurring conditions that can occur. So common ones are ADHD, for example, autism spectrum disorder, OCD. And in terms of diagnosis for tic disorders particularly, it's usually done, there's no kind of unanimous test to be able to work out whether you have tic disorders. It's more done by observation and looking into kind of personal history. But there are other differential diagnoses in adulthood that maybe should be explored or considered, especially if somebody's coming in with, saying that they've got tics in adulthood. That should be explored, such as, thyroid dysfunction, which can cause tic-like movements to occur. So I'm going to see if I can make these videos work. So this is an example of Huntington's chorea. So again, those movements, instead of tics, which are quite kind of rapid, kind of non-rhythmical, chorea kind of has a more kind of dancing formation to it, and kind of more flowing movements that occur. For example, with dystonia, which is another movement descriptor. As you can see, it's kind of, it was almost like focused on a point, for example, and they tend to stay there rather than, for example, with a tick like that one, it kind of, you do the tick and it dissipates. And as he's doing here, he's kind of using kind of what's called a sensory trick to be able to try and relieve that kind of notion of staying in place. Okay, so I can go. Right, the next part is that I did a survey of 42 adults, looking into not only confirmed diagnosis, but actual self-identification, especially when people might actually find that they're unable to get a confirmed diagnosis in adulthood. And what we found, that actually found quite a high percentage of people reported an adult onset, which is interesting considering there's kind of a debate of whether that occurs. And there was no significant difference between like tick presentations between adults that had an adult onset to adults that had a childhood onset, which corroborates with some other previous research as well. And over half my cohort were female, and there is a growing body of research at the moment that's looking into kind of the female course of tic disorders, and it looks like females may have like a delayed symptom peak, for example, less remission, and maybe worse impairment outcomes when it comes into adulthood. And 88% of my cohort had at least one recurring condition. So again, corroborating what we discussed before, these adults had high kind of experiential avoidance, if correlated with kind of more overall frequency, intensity, and severity of motor tics, but not for vocal. Interesting. But this correlation seemed to decrease with increasing age. Again, they reported negative impacts of tics felt in social situations such as work and employment, mood, they're affecting their mood or embarrassment level. And unsurprisingly as well, adults face barriers such as long waiting lists and lack of available specialists when it comes to healthcare interactions. And the majority of my participants didn't receive post-diagnostic support. And this is one last part of a paper that I've written, looking into, I did some interviews with 14 participants, which is very illuminating about kind of their journey into their recognition of tics in adulthood and their acceptance of those. And the main themes that kind of came out of that was this theme of minimalization. Participants expressed trying to understand what was going on. It's just an embarrassing thing. It's just a habit. It's twitch. You can stop it. Hiding their condition. And also, again, describing the mental and physical toil that can happen when people try and control the condition. In terms of, accessing a confirmed diagnosis and things, again, when people were embarking on this kind of journey, participants highlighted kind of the luck and privilege involved, of having to advocate for themselves, for example, or gain knowledge, or the luck of interacting with healthcare providers that believed or understood the condition itself. I mean, there are a lack of specialists in general for Tourette's and tic disorders in childhood as well, but there's even more a lack in adulthood, for example. We then kind of move on to what I would just phrase as the anticlimax. So once they received a confirmed diagnosis, there was obviously no cure, but there was kind of like a trial and error process for finding maybe appropriate medication or appropriate treatment. And some participants, including myself, in fact, choose not to medicate due to some of the medications, offering kind of side effects that were often considered quite strong. And my participants, I found, actually weren't initially offered kind of alternative therapies such as behavioral therapies or psychological therapies, even though NICE guidelines often recommend that as the first line of intervention in adulthood. And especially when tics exacerbate in adulthood, there may be a period of readjustment, you know, and a knock-on effect on daily life or employment. For example, people can lose their jobs depending on the nature of what they were doing and things. So there's a bit of kind of adjustment period, I suppose, in terms of, is this the new normal for these people? Similarly, obviously, there's a period of kind to reach acceptance that they have the condition, especially if, you know, they've either been told, you know, maybe from a parental or environmental situation, they've been dismissed, or they've been told it's just a habit or a twitch. It's a process of going through kind of reaching acceptance. And even the last quote on this slide, for example, I find really interesting that the specialist focuses on the more severe side or extreme kind of sensationalist side, and kind of almost invalidates the person's experience of what they're going through. And lastly, people found that diagnosis gave them a perceived form of protection, you know, often, especially in public or from the law. You can get kind of like ID cards, although that often requires, say, a confirmed diagnosis. So people who self-identify don't have access to those. And there's also a perceived sense of responsibility and representation, you know, when you're explaining the condition to other people. But the confirmation could also bring a sense of belonging and actual access to kind of the Tourettic community, whereby people kind of share experiences and support each other through their condition. I'm just looking at time. I think I'm just about on time, so I will skip the last one. It is a video which just kind of explaining different experiences, but we've kind of covered that already today. So thank you very much for having me, and I look forward to any questions people might have.
I think whilst I wait for people to put questions in the Q&A, I'm just going to say, can you discuss a little bit about the difference between stimming and tics?
Yeah, absolutely. And actually, I can go through my personal experience as well. So stimming is often, it kind of has a different kind of purpose or feeling to it. So stims are often like repetitive, like kind of rocking or self-soothing. You know, I tend to rub my hands, for example, as a stim, and it kind of acts as that kind of self-soothing, or in my case, I use it as a kind of a focusing tool for concentration. Whereas tics, I would say, are a bit more disruptive. They're not really self-soothing at all. They're things that you have to do in term to kind of relieve a sensation or kind of an urge to perform that tic. So it's the difference really is more to do with the type of movement that's occurring with stims. As I say, it's kind of more rhythmical, more kind of like soothing, compared to tics, which are kind of more rapid and kind of to relieve something quite quickly, I guess.
Okay. What advice would you give someone who's going or thinks they might have tics about how to approach the diagnosis?
And again, so I think my personal experience, and again, I'm very lucky in the sense that, you know, I have access to education and things like that, is that when you're going for diagnosis, be able to understand, you know, maybe the personal history that you have with tics. So if you can recall anything that happened earlier on in life as well that might have been tics, kind of do maybe a bit of journaling to kind of really understand when you're having tics, what kind of triggers there might be, whether you're having urges with them or not. things like that, and also be prepared. So when you approach a healthcare provider, make sure that they understand that this is obviously causing you this, how it's manifesting, and be very clear about what you would kind of want out the process. They might need a bit of holding in terms of, for example, I had to ask for a referral to a neurologist to confirm my diagnosis, because sometimes, not always, but sometimes healthcare providers may not have encountered this tic disorders before, and therefore you might need to prepare yourself and educate yourself on the condition before approaching.
What would you like to know, for someone to know about adulthood and tics, and how it might be different from what you'd be observing in children? What would be the key take-home message that you would want someone to know?
I think it's more about acceptance, actually, because I think a lot of the time, because people kind of assume that it might kind of dissipate in childhood, that it kind of means that people like myself who maybe exacerbated in adulthood, it's quite scary, and you don't get the same kind of level of acceptance, I would say, in adulthood. So what I really would like is for people to understand that it can and is a lifelong condition, that but it shouldn't stop you as well. Even though I was talking about readjustment earlier, for example, mine occurred later on in life, and I had to kind of readjust, but it didn't stop me from pursuing what I wanted to pursue. I may just need to readjust what I was doing. So I think in general, it's just about hopefully having a supportive network around you, really raising more self-awareness in public and in the public eye in regards to that Tourette's in adulthood can occur. The lack of like trying to actually advocate for what happens on a day-to-day basis rather than the kind of sensationalism of that the media kind of portrays, and just being aware of the support that is actually available for you to thrive as an adult, even despite the condition.
And there's a question here about medication and the side effects that often go in line with epilepsy medication, about being slightly slower in responsiveness and ability to keep up the conversation. Do you find that there are similar effects with the medication used to control the tics?
Yeah, so I've gone through a couple of different medications, and you're right. I mean, sometimes they're antidepressants or antipsychotics. It really depends on the type of medication that you've been prescribed, but obviously the associated side effects of those can be kind of this slogging thing, this kind of almost a sense of, I think some of my participants said a sense that of like part of the life of them had kind of like been taken out of them because they're kind of a bit more slow to respond, things like that. So I mean, it depends what works. I think that's another thing, is that if you're thinking about this journey, that you have to kind of do what's right for you. I don't medicate. I do self kind of management. I find exercise, for example, helps. I find a few other things that help, and so you just need to be aware of the types of medications that they are offering you as well, and how that might help or exacerbate your tics regardless. So yeah, it's a very difficult one, is medication to kind of monitor.
I think we're done with the questions.
Ooh.
Have you got anything else to say?
No, other than it's been absolute pleasure to talk to you today, and I hope you've learned something a bit about Tourette's in adulthood, and just be nice to people. That's all. I think that's the take-home message, is the fact that, like, if people are struggling, help them. Sorry.
Thank you, Danny. Thank you so much. And it's a really lovely note to end on. I think, you know, a bit of kindness goes an awfully long way, doesn't it? But yeah, so, and I think that the whole thing about understanding and supporting is so fundamental for the whole of, you know, Neurodiversity Celebration Week. Doesn't matter what we're talking about. That's always kind of like a key part of it. But thank you very much. And it was kind of really interesting and really interesting research. And, you know, wish you well with kind of like where that goes in the future. We do have more lunch and learns this week. And actually the one tomorrow that we're hosting, which is at 12:30 tomorrow, is looking at the workplace. And interestingly, we'll be picking up on a few of the things that you talked about, Danny, in terms of disclosure, advocacy, and adjustments. So that's tomorrow's lunch and learn. And then we've got a further one on Friday at 12 o'clock, where we've got Daly Jones from the Met Police, who's going to be talking about ADHD and the emergency services, which sounds really interesting. So sort of lots of different things across the week. If people are interested, do come along. But I think that kind of brings us to an end. Unless Danny or Amanda want anything more to say, I think we can close that there. Thank you so much. Thanks to everybody who came along today. Thanks very much. Bye.